Thank you very much, Des, for that. We really appreciate that. And like you said, we're going to make the slides available to all who has requested it. For those who just joined us, we want to welcome you. Our next speaker, her name is Dr. Folashade Olajubu. She is a consultant forensic psychiatrist. She has worked within the NHS for over 30 years. She's a senior mental health professional, and she has worked both in Nigeria and the United Kingdom in variety of mental health settings. She's currently working for the NHS as a consultant forensic psychiatrist, working in secure services in Kent. She has also worked in medical education and is the forensic training program director for Health Education England. She is an accredited therapist in cognitive analytic therapy. She's also an honorary senior lecturer with Christ Church University, Kent. She is a mentor for a number of female professionals within and outside of her profession. She is passionate about mental health provision for Black, Asian, and minority ethnic people. Thank you very much, Dr. Fola, for joining us. And we're going to ask you to unmute yourself so you can do your presentation. Thank you so much.
Good morning, distinguished ladies and gentlemen. It's such a privilege and an honor to be here. And I just want to start by saying thank you first and foremost to Mrs. Olajubu and her organization for inviting me to speak today. And also I want to say a really big thank you to Des. I found your presentation very informative. And as people who've been here from the beginning, I am going to touch on some similar themes. At this point, I'm going to try and share my screen. And I'm just wondering if there's a way of letting me know if my screen is being shared, please.
Yeah, we can see it.
Fantastic. Okay. So, as I said, I'd like to start by thanking Mrs. Olajubu for the honor of being here today. I'm not going to repeat who I am because that's been described adequately. And so I just want to start by saying that today I think that this conference is really aptly titled, Bridging the Gap in Health Inequalities of Black Communities Within Mental Health and Social Settings. And so I started by saying that the World Mental Health Day, which is actually falls on a Saturday this year, is a program by the World Mental Health Federation, and it was commenced on October the 10th, 1992. And this year's theme is Mental Health for All, Greater Investment and Greater Access, Everyone and Everywhere. So what message is the World Health Federation trying to communicate? I went to check that out, and the president of WMHF noted that the individuals the world over face unprecedented challenges to their mental health as the world grapples with COVID. And there is no doubt that this is a pandemic unlike any seen in our generation, whose tentacles have insidiously extended to every facet of our lives, wreaking havoc and causing worsening health in its wake. And when I say worsening health, it's not just the absence of infirmity, but a state of physical, mental, and social well-being, which is the definition of health as given by the WHO. As a senior mental health practitioner, I have seen firsthand how COVID has precipitated heightened isolation, fear, emotional distress and trauma, anxiety, relationship breakdown. I just want to bring up the slides. Bereavement, trauma, and a general worsening of mental health in peoples of all ethnicities as people grapple with the knock-on effect of living with COVID. It is the exemplification of what I call the strange situation, where every day individuals are facing disease, destitution, and death, against the backdrop of very necessary infringements of our civil liberties to try and curtail the spread of the virus. Tentatively, getting on a train about a week ago, I looked around the carriage with everybody donning masks and attempting to social distance. And I thought of how we look like actors and actresses in a sci-fi movie. But this is anything but fantasy, and this is anything but entertaining. This is an extremely frightening reality impacting on every aspect of our lifestyle and our mental well-being. At this point, I just want to highlight that even before COVID came onto the scene, mental health statistics were rather dire. There are 450 million people who live with mental disorders worldwide. Mental disorders are the leading cause of ill health and disability worldwide. 1 person in 4 will be affected by mental health disorders in their lifetime. Mental disorder and substance abuse accounts for 13% of the global health burden. Every 40 seconds, somebody somewhere dies from suicide. Over 800,000 people die globally from suicide annually, and suicide is the leading cause of death of males in the UK between the age of 20 and 49. However, COVID has once again highlighted inequalities with worsening health indices for individuals of BAME origins. I'm not going to define BAME because Des did a great job of doing that. It is a known fact, though, that in race-conscious societies, the non-dominant racial groups have worse global health than the dominant racial group. To quote Professor David R. Williams, Professor of Public Health, Harvard University, "We're in the same storm, but we're riding in different boats." So, important influences on BAME communities' mental health in all populations, UK included, are as follows: racism and discrimination, social and economic inequalities, mental health stigma, the criminal justice system, and some other factors which I'll refer to later. The interplay between these factors and mental health are complex, and they're not necessarily linear in causation. Safe to say, BAME individuals are exposed to increased economic, social, racial, physical stressors, which have a deleterious impact on health, be it social, physical, or mental health. And we've heard Des talk quite explicitly about trauma. So at this point, I feel it's really important to actually just describe some key definitions, because whether we like it or not, racism has a main role to play in our experience of mental health as BAME individuals. So, racism, it can be defined as prejudice, discrimination, or antagonism directed against a person or people on the basis of their membership of a particular racial or ethnic group, typically one that is a minority or marginalized. Inherent advantages, possessed by a white person on the basis of their race in a society characterized by racial inequality and injustice. So simply put, we're being discriminated against due to the color of our skin and due to our ethnicity. Second definition, white privilege. It's inherent advantages possessed by a white person on the basis of their race in a society characterized by racial inequality and injustice. And finally, microaggressions. And I think this is the one that many people who are not from our BAME communities find really difficult to understand. They are statements or actions or incidents regarded as an instance of indirect, subtle, or unintentional discrimination against members of a marginalized group, such as racial or ethnic minority. And I'm actually going to give some examples of microaggressions for our white colleagues. So, unfairly given the jobs that no one else wants to do. When different opinions are helpful, ours are not sought or asked for. We are watched more closely than others. Supervisors and co-workers use racial or ethnic slurs or jokes. We feel that we have to work twice as hard as others. We are often ignored or not taken seriously by our line managers. Others often assume that we work in a lower status job than we do and treat us as such. And I'm going to give a personal example of that. A co-worker with less experience and less qualifications gets promoted before us, and we are often unfairly humiliated in front of others at work. And that is based on a study by Professor Williams et al. At Yes Health Study. And just to give that example, a very live one that I have experienced. So as was explained, one of my roles is I'm a consultant forensic psychiatrist working in one of the main secure service in Kent. And I always remember a couple of years ago, there had been a service reconfiguration and I was heading up a ward round and my patient was white and his family joined the ward round. Now, I'm almost sure that when I introduced myself as a doctor, I introduced myself as a consultant, I introduced myself as a responsible clinician, and I had my name badge on. But possibly because I was sitting behind a laptop and I was jointly chairing the meeting and taking minutes, it was assumed that I must be admin staff. Now, there is nothing wrong with being an administrator. It is a completely honorable job. But it was very interesting to me that the patient's carers just couldn't equate me with being the consultant. So at the end of all the discussion, they asked a question that could only be answered by the person who was ultimately responsible for their son's care, myself. And they turned to the white colleague in the room who was a nurse. I don't really know who was more embarrassed, other members of the multidisciplinary team or the nurse herself, when she highlighted that the response that they needed was from the responsible clinician, and that was I. Of course, if a year later, when I managed to get the patient discharged after him being in hospital for about 10 years, a rather derogatory comment was made by the parent's father. "Oh, you're quite clever, aren't you?" Now, these are the kind of microaggressions that we face every day, which impact on our mental health. But it gets worse. So, looking at social economic disparities, again, Des has touched on them, but social well-being and health will impact on your mental health. So these are the things that we face. BAME populations are predominantly living in the most deprived areas of UK. There is a marked disparity in wealth generation. 16 to 24-year-old unemployment rates are highest in BAME populations. BAME individuals are paid less in comparison to white counterparts with equivalent education and qualifications. There is an increase in prevalence in homelessness. 37% of statutory homelessness is from BAME backgrounds. We have poorer maternal mortality rates amongst BAME women. There are also poorer infant mortality rates in BAME populations. Because of toxic stress, which Des has explained, we have a higher prevalence of obesity, hypertension, diabetes, and other mental disorders. Our life expectancy is lower. And of course, you have to have been hiding under a rock if you don't know that for us, we have worse outcomes in relation to COVID-19. And then we have to think about mental health and stigma. Ignorance and stigma, and now I'm going to kind of switch because I think it is important to actually say that ignorance and stigma are still the two elephants in the room when it comes to mental health and mental illness. I believe that people from BAME backgrounds still require some considerable education around mental health literacy and practical support to raise awareness of mental health conditions and combat stigma. There is a need for improving information about services and access pathways. Healthcare providers do need relevant training and support in developing effective communication strategies to deliver individually tailored and culturally sensitive care. Improved engagement with people from BAME backgrounds in the development and the delivery of culturally appropriate mental health services, hopefully could facilitate better understanding of mental health conditions and improve access. However, it must be noted that we from BAME populations have a more negative experience of services, leading us to disengage and consequently increasing the risk of compulsory detentions under the Mental Health Act 1983. Des has spoken so articulately about the criminal justice system, but I just want to highlight a few things. So I'm going to refer to some MOJ statistics, by that I mean the Ministry of Justice, and I'm also going to focus on some of the findings of the David Lammy Review 2017. So I think the key thing to highlight first and foremost that as a people, and we're not a homogeneous people, but we do make up 14% overall of the UK general population. And the Lammy Review highlights that those who are charged, tried and punished are still disproportionately likely to come from minority communities. The report notes that there is a racial stereotyping of young Black men as dangerous, violent and volatile. and Black men with mental health difficulties are seen as mad, bad, and dangerous. Therefore, Black people with mental health issues face double discrimination. So I just want to highlight some of the statistics. Some of them I'll be repeating, Des. BAME individuals make up 25% of the prison population, even though we only make up 14% of the general UK population. Over 40% of young people are from BAME populations in prison. BAMEs experience differential treatment. A BAME defendant is more likely to attract a custodial sentence. BAME populations, we are 3 times more likely to be arrested, 9 times more likely to be stopped and searched, 5 times more likely to have force used against us by police, and Black people are twice more likely to die in police custody. And quite worryingly, we're more likely to access mental health services through the police or the criminal justice system. Just a few other factors which impact on our mental health. The following also impact. And part of it is the cultural perception of and access to interventions in the following domains. So disability, matters around sexuality, gender issues, and the prevalence of domestic violence, and services to address all of those. So, as you know, I'm a psychiatrist, and I want to bring you back to the sad reality in terms of some statistics about mental health or mental illness. So the ASOP study was an etiology and ethnicity in schizophrenia and other psychosis study. It's one of the largest studies in this country, and it highlighted the following. The risk of psychosis in Black Caribbean groups is 7 times higher in comparison to white populations. There is a 9-fold increase of developing schizophrenia in Black Caribbeans as compared to white British populations. There's a 5.8 increased risk of developing schizophrenia in Black Africans as compared to the white population. And there is a 1.4 increased risk of developing schizophrenia in Asians who are designated South Asians, such as Bangladeshis, in comparison to the white British population. And it's clear to see that amongst one of the hallmarks is the fact that we experience much higher levels of trauma. The Mental Health Foundation also highlighted the following. Detention rates for Black British people are 4 times higher than white counterparts, even though we are only 14% of the general population. And although suicide generally is higher in Caucasians, it has been found specifically that there are higher suicide rates in young Black men, Black middle-aged men, and South Asian women in comparison with their white counterparts. So, coming back to today's theme, the aim of the theme for this year's World Mental Health Theme is to promote a focus on universal health coverage, which is a key target in the Sustainable Development Goal for good health and well-being. This is one of the 17 Sustainable Development Goals identified by the United Nations to improve our world. The World Mental Health Federation articulates this as follows: that all people have access to quality mental health services they need, when and where they need them, without financial hardship. The Director General of WHO has stated that mental health must be an integral part of the universal health coverage. And to quote the Department of Mental Health, there really can be no health without mental health. At this stage, I'm going to take you a bit on memory lane. I recall that I was present when the former Prime Minister, Theresa May, delivered the annual Charity Commission lecture in January 2017. She said that true parity for mental and physical health could only be achieved if every institution recognized the vital role it can play in delivering this objective. During her speech, she said, and I quote, "For too long, mental illness has been something of a hidden injustice in our country, shrouded in a completely unacceptable stigma and dangerously disregarded as a secondary issue to physical health. Yet, left unaddressed, it destroys lives. It separates people from each other and deepens the divisions within our society. Changing this goes right to the heart of our humanity, to the heart of the kind of country we are, the values we share, the attitudes we hold, and our determination to come together and support each other. And she went on to say, I want us to employ the power of government as a force for good to transform the way we deal with mental health problems right across society and at every stage of life. However, I recall very vividly coming out of that meeting feeling quite frustrated, because when she set out her agenda, there was no mention of a targeted focus on BAME populations. So I want to highlight what have been identified in various studies as some general barriers to service provision. One, recognition, I beg your pardon, so waiting times. No, I'll just go back a bit. So I want to first talk about the personal barriers. So these include a recognition of mental health difficulties. So that's individuals recognizing that they are struggling with their mental health. It involves social networks. So I read a study where a young woman was interviewed, and she said that nobody in her social network had even understood the concept of depression. Then there are sex differences, by that I mean gender. So males are less likely to talk about their mental health difficulties, and by extension, less likely to actively seek out mental health services independently. Of course, we've talked about cultural identity and stigma, and also financial factors. So for example, as Des rightly spoke about, ideally when you have a mental health difficulty, the starting point shouldn't actually be medication. And I say that as a senior practitioner who's a medical doctor. Many times when you have a mental health difficulty, you might, however, need therapy of some form, so a trauma-based therapy or psychotherapy. And unfortunately, the waiting lists in NHS are this wide. And when people try and access them privately, they are incredibly expensive. Talking about barriers, service provision barriers. Well, there's quite a long list, but I'll start with a few. So waiting times, the waiting times for accessing services, for example, psychotherapy, are ridiculous. The issue of language. So not everybody has English as their first language, and there is inadequate provision of interpreters to facilitate meaningful communication. And I go on to the next point, because of course, the next barrier is communication between different service providers and stakeholders. Service provision barriers, being responsive to needs, and we've highlighted that today about the need for culturally sensitive and appropriate services. The issue of power and authority, and very aligned to that, of course, is systemic racism. And then there is, again, cultural naivety, insensitivity and discrimination, and even an awareness of what services need to be provided. I know Des noted this previously, but I'll say it again. There is a need for cultural competency. So research points to a strong need for greatly increased cultural competency in mental health services. And this may include some of the following: practical improvements in language, interpreting, translating, I beg your pardon, and literacy support. Des spoke about faith. So meeting faith-related and religious needs, very important for us from BAME backgrounds. Culturally appropriate food. You're going to a day center or residential placement, and yet the food is not culturally appropriate. Gender-specific services and staff, and definitely increased diversity of staff. It is I think it's almost impossible to work efficiently in providing mental health services without diversity of staff understanding various cultures. I believe there must also be positive actions to address and reduce the experience of racism and discrimination. I'm going to say it over and over again. I'm reminded that I think it was in 2012, commissioning for mental health services was reconfigured in this country with the introduction of integrated care through the clinical commissioning groups and local authority social care funding. And at that time, they said that the following regarding service provision, that service provision for people should be made available for those currently experiencing mental health problems, that services should be made available to promote prevention of mental illness and mental disorder, that there should be services with a focus on early intervention, so that's a focus on high-risk populations, and services to address mental health promotion. In theory, there was a recognition that service provision needed to encompass not just healthcare per se, but social care, employment services, supported accommodation services, and services to meet individual wider social, cultural, and spiritual needs, where these relate directly to the person's mental disorder and to help reduce the risk of deterioration in the person's mental health condition. However, sadly, I'm of the opinion that this does not appear to have been translated into targeted BAME mental health service provision. Finally, in thinking about the theme and about the topic I've been given to speak about today, I want to refer to the National Mapping of BAME Mental Health Support Review Report by Carl Murray from the Black Training and Enterprise Group, which was released in August 2020. So Carl Murray led a study conducted between May and June 2020, and this survey sought to map the Black, Asian and minority mental health and wellbeing services in UK, with the aim of being able to start the process of capturing BAME-led mental health services, as well as to gauge an understanding of how these organizations are being impacted upon as a result of the COVID pandemic. Some of the highlights of that report was that there was an increased demand for BAME mental health services. However, there is a lack of BAME mental health provision. Mainstream providers and BAME-led organizations acknowledge that there is a lack of cultural competencies and perspectives in their work. Commissioners are aware of equality issues, but do not, and I emphasize that, do not factor these into the decisions they make when commissioning services. BAME-led service providers are in need of capacity building and infrastructural support. And there has been an increased move to online services, which has created a need for infrastructure to support migration from face-to-face to online interactions. And so the recommendations of that report for me are representative of greater investment and greater access. So the recommendations were as follows. One, in terms of bereavement support, the need for national BAME bereavement service that meets the cultural needs of the community, and bereavement therapists and service providers which have cultural competency that is quality assured. So, commissioners and funders of mental health, more, and I emphasize, more needs to be done in relation to funding, capacity building, and commissioning of BAME mental health services, especially around bereavement and mental health services. Then the next item was training in cultural competencies and race equality for NHS and statutory providers. And it was identified that there was a need for training in cultural competencies and equality impact assessments, and that there needed to be the recruitment and training of additional BAME counsellors, psychotherapists, psychologists, and mental health practitioners. Then going to the mainstream third sector providers and infrastructure organizations, it was acknowledged that there needed to be a joining up of services working with existing mainstream providers, such as Cruise Bereavement Care and the National Bereavement Alliance. It also highlighted that there needs to be technical and awareness training around bereavement support, mental health awareness that is culturally competent by BAME-led organizations and providers. Finally, they highlighted that more research needed to be undertaken on the impact of COVID-19 on BAME bereaved families, and that the Department of Health and Social Care, in conjunction with NHS England, needed to develop a mental health strategy on COVID-19 and BAME communities. And finally, that policymakers, there needed to be a grant scheme for BAME bereavement services and mental health services. So finally, I just want to end my talk by addressing Enfield Council. I know that the organization that has invited me today is based in Enfield. And I went to look at some information on Enfield Council yesterday, and they said that they have a commitment to equality and diversity. The write-up I read highlighted that 39% of the working population in Enfield are from the BAME community. And they said that Enfield is committed to improving access services and the local environment for all. They highlighted that there was some deficiencies in terms of employment for those with mental health difficulties. And they stated that they were in the process of building a wellbeing hub that would support employment, wellbeing, enablement, and housing. And there seemed to be a push to state that their children and young people's services were equitable with other services in the country. However, bearing in mind what I've just read from the mapping report, I'm left with a sense that Enfield Council, most respectfully, has quite a long way to go. And I would respectfully ask that they look at those parameters that have been identified from that report and begin to work towards implementing them. At this point, I would just like to say thank you. Thank you for listening.